Well, good afternoon and a very warm welcome to this latest edition of the webinar series. I'm Jeff Hogg, a clinician scientist based between NHS Trust and the University in Birmingham. And this NIHR Supporting Incubator is a cross-sector community aiming to collectively advance regulatory science and innovation in AI and digital healthcare. Our demand-led webinar series gives us the chance to invite experts to share their work and insights in key areas and create an opportunity to dig into various exciting topics and share ideas and challenges. The format of this session today is going to hold that in mind. So soon we'll be able to enjoy the presentation from our speaker. And if you can join me being in listening mode for that part, you'll notice a Q&A button at the bottom of the screen. So throughout the presentation, you'll be able to type any questions that occur to you in there, but we won't dig into them until the end of the presentation. We'll have ample space there for those questions and discussion. And I can, through the power of Zoom, either unmute you and invite you to speak to them, or if we have a bit of a tech failure there, I can read them out too. So please don't let that hold you back if you're not in a place where you can speak. Also, if we don't manage to get to your questions, don't let that worry you. They're really valuable to us and they'll help us plan future sessions or interesting topics for later dates. Just as a little further note of housekeeping, we'll be recording today's session too, and we'll host that on our website, so you can rewatch that or refer back to it at a later date, or recommend it to colleagues who weren't able to join us today. So moving on to the main focus for today, for the past year or more, technologies enabled by large language models have been front and center in conversations about AI innovation in health and beyond. But these technologies, how these technologies can be expected to perform in practice, and which ones are compliant with regulations has not been quite so clear. Ambient voice technologies, or AI scribes, as they're sometimes known, are one of the most prominent examples of these technologies. And today we'll be hearing about one of the earliest UK evaluations in health and care settings of these technologies from our guest speaker, Jenny Partridge. Jenny's an innovation manager at Health Innovation Kent, Surrey, and Sussex. She's worked in primary care for over 12 years and has a specialist interest in AI within health innovation. So if I could invite you on screen, Jenny, and to share slides, it's a great pleasure to have you with us speaking to the title of Is Ambient Voice Technology a Game Changer for Healthcare Professionals? It's great to have you here.
Thank you very much, Jeffrey. And let me just get my slides up. Check they're sharing okay.
That looks fantastic.
Yep, are we on?
Great.
So thank you for the opportunity to come and share the work that we're doing in the Health Innovation Network on ambient voice technology. When I chose this title, I thought it was relatively unique, but actually as I've been researching this presentation, clearly an awful lot of people have got exactly the same idea, asking whether or not it is a game changer for healthcare professionals. And as we go through the presentation, hopefully you'll be able to form your own opinion and we can have a debate about that at the end. So just by way of introduction to the Health Innovation Network, if you're not aware of us, our role is to help spread innovation, to help bridge the gap between innovators and the health and social care system in order to improve patient outcomes and indeed staff outcomes as well. We're funded by the Office for Life Sciences and the NHS. Office of Life Sciences because we are aiming to promote economic growth and help innovators who have well-evidenced innovations and products to spread that into the NHS system, health and social care system, which is notoriously hard to access. I work for the Kent, Surrey and Sussex area, but I do work with colleagues across the network in England, and there are 15 networks. So the reason that I thought I'd start with the 10-year plan, this is a very topical subject. Wes Streeting spoke about it in April when he talked about an AI doctor's assistant being there to speed up appointments. And very recently we've had the the results of the Great Ormond Street-led trial of AI scribe technology, which showed transformative benefits. And what we've done in a Health Innovation Network is we've also carried out a number of evaluations, which I'll share with you. Really just to show the speed of development in this arena, in June last year, we hosted a roundtable looking at AI and automation in primary care, jointly with the Health Foundation and with guests from across the southeast, including NHS England, innovators and primary care leads. And at that stage, one of the ambient voice technologies was demonstrated, and people in the audience were very impressed. And I think from that, some of the trials that we then ended up evaluating sort of came from there. And then more recently, my colleagues in South London, in South London, looked at AI that was being used in clinical settings, but wasn't clinical. So it wasn't looking at lung scans and things of that nature. This was all about sort of supporting operational work within the healthcare setting. And what you can see from this slide here is that most of the innovations that they looked at were in the space of looking at staff efficiency, and particularly ambient voice technology. And then you can also see the spread across the country of where those innovations were currently being used. Now, this is a survey amongst Health Innovation Network, so it's not absolutely solid, but it started with 190 innovations, got it down, I think, there to 89 innovations. And you can see the spread across the country as well, with, unsurprisingly, London being prominent. So what I'm going to do today is just very briefly a quick overview of what AVT is, but more importantly then getting into the application. So I am not an AI specialist, I'm not a technical person. This is very much about how is AI being used, how AVT is being used, the evidence for and against, and then some considerations for implementing ambient voice technology. I've spoken to a number of clinicians who have used ambient voice technology in some of the pilots that we've supported. So we've had some very interesting learning from their experience. And then finally, we'll look at the evaluation findings and have some time for questions at the end. So my thanks to Stefan Hanhart at Surrey Heartland's digital primary care team, who put together this one slider on what is AVT and how does it work. They used it internally in Surrey Heartlands earlier this year when they were looking at different AVT models, and they're testing some at the moment. I'm sure most of you are already familiar with it, but it's really just to, I think it's very important to start with an explanation of what we're talking about. And we found this particularly in the healthcare settings where they've implemented AVTs. Sometimes people have quite different expectations of the tool and what it does. So this is all about listening in, converting audio into text, and then presenting a summary of that text or that transcribed text in a certain format that has been prepared earlier by the supplier of the technology. And that's where the skill comes into it, because actually recording conversations is very easy and we can all do it on our phones these days. So let's look at the uses of AVT, and these are use cases based on our experience across the Health Innovation Network. So the prime use, which I'm sure everybody's familiar with, is that clinicians using it in one-to-one consultations. I've got there that 25% of GPs are using AVT in some form or other. At various times I've heard up to 50% of GPs. I don't think that's true, but a significant number of GPs are using AVTs in some form or other. And indeed, many of them individually have driven the adoption of ambient voice technology in their practices. And then there's also a large range of hospital doctors and consultants in both acute and outpatient settings who are using it. Social workers, another use case, who have been using AVTs for a long time in home visits and for care assessments. And Magic Notes is the prime supplier to over half of local authorities. We're also aware of trials being underway in community and district nursing and having some very interesting impacts there. Particularly in the mental health trials with ADHD and autism assessments, where those assessments do take a lot of time. And then there's the administration teams who are using ambient voice technology to record team meetings, summarise those to save time writing up the minutes, And of course, MDTs, which a number of people have managed to use Ambient Scribes successfully for for MDTs, but it does need careful template management because of the number of different patients being spoken about and the typical number of people participating in an MDT. And then finally, there's trials currently with the ambulance service in London, the acute care hub teams using AVTs, again with some very promising results. So there's a lot of evidence for using ambient voice technology, not least because so many people are using it already. Staff are asking for this tool and finding ways to use it. For many of them, they'll say the benefit is that they're able to better focus on the patient and look at how they are speaking, how they are presenting, rather than just having to face the computer and type up notes. It means that they can let the patient flow more readily rather than having to sort of stop-start the conversation. And it's quicker after the consultation to write up the notes and plan the next steps. Also, interestingly, some clinicians with neurodiversity have said that ambient voice technology has made a significant difference to how they work in a positive way. From the surveys we've done with patients, many of them say they appreciate having eye contact during consultation and feel that they're being listened to, maybe more so than they were before. And they appreciate having quicker access to notes after the consultation. And then we've measured efficiency or return on investment and some of the evaluations we've done and shown that there's a positive return on investment across a number of different settings from using ambient voice technology. The major impact being a reduction in clinician workload or admin workload, but it also impacts on cognitive load and reduces the risk of burnout. And in fact, one of the trials that we've supported was very much predicated on the fact that this was there in order to help with staff well-being and prevent burnout, as opposed to that saving time as a return on investment overall. In some settings, we are aware that using ambient voice technology has also increased the number of patients that are seen in a shift or in a day. And here's some quotes just to share from people that have trialled ambient voice technology. So you see there the acute outpatient staff member found it very useful to be able to focus on the conversation with the individual they were seeing rather than worrying about writing something down or writing everything down and missing something. And then the primary care user has likened using tortoise to a natural extension of themselves, and now that like their right arm. So quite a symbolic quote from them. And then moving to some social care use settings, this has been where Magic Notes has been trialled, and first user talks about how ensuring the person's voice is heard and saves them time. And then the second user really emphasising how it's recording relevant information and leaving out irrelevant information. And in something like a care assessment process, which can take a couple of hours, that's really important. They also talk about the benefit to them of it being less monotonous to write up the assessment. There are, however, some concerns that have been rightly raised about using ambient voice technology. So there's the impact on staff and concern around the impact of not writing your own clinical notes. Is that part of the processing that you do in order to assess what to do with this patient? Does it help you remember the patient better? Is there a danger of losing clinical skill in terms of how you take relevant notes? And what about the next generation of clinician training and how do we train them to use this technology safely? And is there a risk that having greater efficiency in writing consultation notes will lead to greater expectations on workload? Because it's meant to be solving the workload issue, not adding to it. And there's also the risk of reliance and how reliant will clinicians get on the technology. And we've certainly seen that when a trial has been maybe 3 months long, a real push at the end to say, look, we need to extend the trial. You've given us this technology, you cannot now take it away from us. So that does put pressure on ICBs or whoever is running that trial. Then turning to patients, what's the impact on them? What are the concerns there? Well, there's always a concern using AI about how accurate it is at recording the conversation. we came across in the early days of looking at some products, we came across some fairly simple things like default male being used, even when the people speaking were female and had female names. Use of Americanisms, words like mom instead of mum, and that has a big impact on the trust for the AI. Now, a lot of that has been ironed out over the last few months, but just interesting to note that those are some of the things that have happened. So it's a question about how safe is that AI, and the risk of hallucinations, or the risk of interpreting the AI interpreting information in a way that may be incorrect. So again, another early example of this that we saw was if one patient had come in and been asked, have you got any allergies? And they said, no, I don't have any allergies. And then that question was not asked next time. We did see that the AI might write no known allergies, but the question hadn't actually been asked. So that has again been ironed out. But these are the sorts of things that are easily done. You can see how an AI tool might make that assumption, but it's incorrect. There's also the risk of bias. So how has the tool been trained? What sort of data has it looked at? Does it understand different types of demographic, different types of people, how they're speaking, what the same kind of terminology? You have local dialects and different expressions. So how well is that understood? And then you've also got where the data is stored. How long is it stored for? Is it stored safely? And who has access to it? Or is it stored at all? And then the other concerns are the potential impact on health inequalities. Talked a little bit about that with the risk of bias. Does it exacerbate health inequalities? There's also a risk of automation bias. We do tend as humans to get over-reliant on automated recommendations. And we saw this in the early days of Google Maps. The number of people that tried to drive through rivers or off a cliff because Google Maps said so. And it's like, how can we be that stupid? But there is something about the computer tells you to do it that people become a bit over-reliant on it. And there may be other unintended consequences of using AI that we do not yet fully understand. And that is the subject of a paper that was published just a few weeks ago, focusing on the unintended consequences of using ambient scribes in general practice, where they've seen a lot of adoption of the use of ambient scribes with high potential benefit, but a lack of evidence on indirect and long-term effects of using those scribes. So the advice there is to use the technology with diligence and caution, and we would certainly echo that advice. So in terms of considerations for implementing ambient voice technology, these recommendations are things that we share quite often at webinars that we give, really to make sure that people do understand it's not just as simple as plug and play. You do need to look at, very importantly, things like the data and the information governance. Where's the data being held? How is it being processed? And have the necessary medical device regulation certification and ID certifications been completed? And has it been signed off appropriately by the right level of person within your organisation to say it is safe to use? There's a lot of new regulation and guidance that's come out on that in the last few months, which I've got a slide on next. We are all surprised that the clinician doesn't always realise that they are fully responsible for the accuracy and quality of the notes, and they need to sign that off. Can't just copy and paste without checking. And that's a key part of any training that should be done when implementing ambient voice technology. And then in terms of the actual technology to use, there's a number of suppliers out there. Some are better for different settings than others, and the template design is key. So what are you using the software for? Is it a 10-minute consultation? Is it actually a 2-hour assessment? Do you want the full details or do you want a summary? So this is very much a piece of co-design work that has to happen between the innovator and the setting. You've then got the whole issue of compatibility with the electronic health record, how you transfer the summary into the record, whether it's integrated or whether it's copy and paste. And interestingly, now that there's more integration available, some people are arguing that copy and paste is better because it makes you stop and think. before just pressing an OK button. And finally, we've touched on this to an extent, but patient acceptability. For any implementation, you do need to consider engaging patients beforehand, helping them understand why AVPTs are being used and how their data is stored. So you're probably familiar with the guidance from NHS England that came out in April 25. I think at this stage there were over 120 products available in the market that were potentially being used across the health and social care system. And this was a case of quick, we need to get some guidance out. So the guidance, you can see summarised there, very much about having to have a clinical safety officer who identified key risks and signed off those risks, ensuring the right documentation was completed for each setting and making sure it's setting specific, planning for the appropriate integration with the clinical record, making sure there's appropriate controls on who's using it and for what use case and for consent, and then making sure that there's ongoing monitoring, because the thing with AI is it doesn't stand still, so you have to keep checking that the model is doing what you expect it to do. And then following this guidance, we got the medical device regulations, which came in July, where AVT tools had to comply with Class 1. So I think when these regulations first came in, we saw a big halt in the adoption of ambient voice technology, and initially 8 companies complied with Class 1 medical device regulation. So if you were trying to find an AVT supplier, it was much easier because you were looking at 8 products as opposed to 120. The list now of manufacturers who comply is 18. You can see them on the MHRA link there. And there are a number of providers who also now work in partnership with, for example, phone system providers, messaging service providers, and some that are integrated into EHR solutions. So there's been a long debate about whether AVTs are a medical device or not. I'm not here to answer that, but I can tell you that many ICBs have set their own rules on implementing AVTs since that NHSE guidance, and particularly since the medical device regulations have come in. Some have stopped using AVTs completely currently, particularly those that are more risk averse. Others are adopting it quite widely. And some suppliers are now working towards Class 2A medical device status, with plans to develop tools on the back of the AVT, for example, to execute associated tasks, such as ordering tests or referral letters following the consultation. So if we move on to the impact of using AVTs, and these are the 2 evaluations that were commissioned by ourselves and took part earlier this year. So firstly, the evaluation of tortoise across 4 different care settings in the Kent and Medway area. There were 58 doctors and social workers who used tortoise across 4 very different care settings. And I'll tell you a bit more about this evaluation, about the project on the next slide. But it started in October last year, has just ended, and we will be publishing the evaluation later in the autumn. And then separately, an evaluation took place of Magic Notes just in the social care service in Medway. This was a test and learn project involving 29 social workers who volunteered to test Magic Notes across 3 areas. That's care needs assessment, occupational therapy assessment, and then general use such as case notes and meetings. And that project started in May, finished last month, and we'll be publishing that evaluation at the end of this month. So if we look firstly at the projects that the evaluation that we did with Tortoise, you may well know them. They're a British company founded by a clinician and have developed the tool that's been developed and tested at Great Ormond Street Hospital. So this evaluation was a mixed methods one, on particularly looking at the impact on staff, patients, and then the wider system in Kent and Medway ICS of using AVTs. It was also intended to support future decision making in relation to the use of ambient AI. It was designed as a multi-site, multi-organisation project, also to test out how efficient it would be. Can you do it once and then share, for example, with your information governance and your safety checks? And what the pilot showed is that Tortoise can deliver both efficiency benefits and staff wellbeing benefits in the real world, but actually there were fewer efficiencies than hoped for when looking at trying to do this across 4 care settings. And there was particular issues with the information governance and clinical safety sign-off. The reasons for that really were that it was a very ambitious project, looking for rapid deployment and evaluation across these very different settings. And although there was a central project team and repository of information and sharing of information, in actual fact, the settings were so different and the risks and use cases were so different that there was less benefit to sharing than had been perceived initially. The product, as was deployed at that time, and that was January this year through to April, May this year, was better suited to some settings than to others. What we did find is that those who engaged with Tortoise the most felt the greatest benefit, and the most positive sentiment was expressed by users in primary care. And the survey showed that 60% of staff felt that using Tortoise helped their patient interaction. I think one of the other findings in this particular study was that the IT infrastructure, which was very different across all 4 settings, as you might expect, was also one of the issues in terms of how smoothly this implementation went. So there's a lot of learning in terms of, sort of how to prepare to use ambient voice technology. And then if we look at the use case with Magic Notes from Beam, and this company was founded by a care worker, it's a social enterprise, and the care worker was spending a lot of time writing up notes and wanted to find a way to make that easier and quicker. So they've been around for over 10 years and are used in more than 50% of local authorities in England and have developing presence in community care. And this evaluation was designed to explore whether or not Magic Notes delivered benefits to social care staff in Kent County Council. The key learning from this one is that the cost-benefit analysis that was done showed that there was a very strong, I'd say, economic case for using Magic Notes, with a return, looking at a 5-year period, a return of £23.30 for every £1 spent. This was based on a test and learn period of 8 weeks on 366 recordings across 169 hours. So it showed significant savings in documentation time of 6.8 hours a week on average and completing assessments of 2.8 hours a week. Also, the number of users who found it easy to use, 96%, so all bar one, and all staff reported that people who draw on care and support were receptive to the use of Magic Notes. So that's some very positive outcomes. So as I said, we then looked at, over the course of these evaluations, I held sort of focus groups with on 3 different occasions with people who were using the ambient voice technology across those various settings. Captured what went well for them, what didn't go so well, what they would advise somebody implementing AVTs to do. And the summary of those findings is here. So unsurprisingly, preparation is key, particularly in terms of looking at what do you want to do with ambient voice technology. Need to understand what your use case is and help you find the right kind of ambient voice technology for your use case. Some are much better in noisy environments, some are better if you're wandering around, you need a microphone that you can wear that might pick up different sounds. If you're dealing with children, they speak and behave very differently, they don't sit still. So all of these findings did show that simple things like having the right microphone and the right technology makes a massive difference to the success of the recordings. Also, how you present those scripts, those summaries to clinicians is important. We talked earlier about templates, so understanding what's needed and co-designing that is really important. Therefore, involving staff and patients early in project design does work well. And in the Kent and Medway case, they did run focus groups, both with with patients, but with staff it was more a case of as they went along, they were asking for developments and changes to the tool. We've spoken quite a lot about the importance of clinical safety and governance. I think the key point there is it does need a local risk assessment and ongoing monitoring. And then staff training is absolutely critical. So we were quite surprised the number of people who didn't have the basic IT skills needed to really take to using AVTs readily. They needed more support than had been planned for in the project. And if the IT infrastructure was wobbly, for want of a better word, then that made things difficult. Also, providing clear instructions on using ambient voice technology safely and liability of the notes was important to emphasise. And also then the right approach to gaining consent from patients, of course, does need to be handled in a consistent way across the organisation. And then finally, communication for every project is vital. In this case, using new technology with multiple stakeholders, the communication was critical, particularly feedback loops, where you might have had different consultants asking for different things from the provider, proved quite hard to manage. So it's one of those things that if you are going to be implementing a new technology, you need to have a clear channels of communication and information repositories to share with your project team. And just to emphasise the knowledge gap in understanding of AI, this is from the tortoise evaluation in Kent and Medway. We found that 60% of people who used tortoise had never heard of ambient AI, and this evaluation was done towards the end of the trial period. So clearly not enough work being done up front to help explain it better to those people who are going to use it and manage their expectations in terms of what it could and couldn't do and what to check for. And my concern is that that's a big gap, and we've done other surveys with people using AI and found a basic lack of understanding of AI as well, despite people using AI tools. So I think across the NHS and probably broader than that, there is quite a big gap there that would be interesting to know if anybody's got any good ideas how we can address that. Then moving on to what's happening now. So after the evaluation, it's always good to hear what happens next. So all of the care settings in Kent and Medway saw the value and the potential of using ambient voice technology and getting the right product for their use case. And what's happening now across the different settings is that one of them is looking at using an integrated ambient voice technology, so one that's integrated already in their clinical system. One is looking at using freemium models, which are widely promoted. And then another one is working with tutors on co-designing templates that are more bespoke for their needs and their particular data collection needs. And then in Kent County Council, the ones with the very good rate of return on investment, they've gone ahead on the back of that and purchased Magic Notes for use by 1,300 social care staff to realise those benefits. So that brings me to our overall findings, which is that these tools can have a significant impact on the time spent writing up clinical notes and assessments, both during and after consultations. We found that staff have a very mixed level of understanding of the technology. Some lack their basic IT skills and risk being left behind as AI tools develop. And what these pilots highlighted was the need to upskill staff in understanding AI, how it works, and safe use cases. And that's beyond AVTs, that's in general. We found that the best impact on terms of AV tools, the ones that work best were those that were developed for particular use cases with clinical input to the template design. They did then capture the right information consistently and safely, built early trust, and therefore got repeat usage. In the same way that any project, if it doesn't work straight away, people are busy and they haven't got time to faff around with moving things around on their computer. They want it to work straight away, plug and play. We also found that there's a lack of consistency in assessing the use of AI and associated risks. particularly not everybody builds in this need for ongoing monitoring to ensure consistent and safe application. And that is something that I know is being addressed through other innovations in terms of middleware that can address this. But certainly in the early use cases we're seeing, that's not the case. Now, I know colleagues of mine are across the Health Innovation Network are also carrying out other evaluations on other ABT tools. Those aren't yet ready to be published, but our website does cover as soon as evaluations are published. We do promote them. So if you're interested in those and what's going on elsewhere, they will be published. I know some are being worked on at the moment, publication over the next few months. So an area that is still very much in the limelight and being evaluated. So I guess that leads to the final question: is ABT a game changer? And I'll be interested in your take on this. But from our point of view, what our evaluations have shown is that yes, in the right settings, with the right safety checks and information governance checks completed, it absolutely is a game changer, and can make a significant difference for staff in terms of their well-being, their approach to work, how they feel about work, and freeing up some time from their very busy workloads. But there are a number of things that we do need to be very aware of when implementing it safely, choosing the right ABT, and making sure that the staff training is in place to use it safely. So I'm going to end my presentation there and see if there's any questions.
Thanks so much, Jenny. There certainly are. That was a really engaging talk and fantastic work. Thanks for giving us an insight into that. I'm going to be attempting to bring people in to speak to their questions. And Thomas Round, just as a heads up, I'll come to you first. But before that, some of the questions, thanks to Zoom, land under a cloak of anonymity. And I'll just pick one of those first, if that's okay, Jenny. Just to ask you to unpack a little bit about what you mean by template design, because I know you flagged that as a kind of predictor of success, the co-design of those templates.
Sure, yes, sorry, it's one of those words I've got into quite a bit now. And interesting, the CCIO we worked with in Kent coined the phrase template engineering. It's basically how is the ambient scribe note captured? So in primary care, there's a lot of SOAP. There's different ways of recording clinical information, and different settings will have their preferred structure. If it's a general meeting note, it tends to just have a who attended, this is what they said, here's some actions. So it's designing, I guess it's the bullet points or the headings under which that information is captured, so that it's easy to read and find later. And certainly if it's clinical notes, a lot of clinicians will have their template for assessing, I don't know, a health check versus a diabetes check versus something else.
Thanks, Jenny. That's really helpful. So I think I've just unmuted Tom or Thomas.
Hi, can you hear me?
I can. Thank you very much.
Great,
Over to you.
great. Thank you, Jenny. Really interesting talk. I have to declare, so I'm a GP with some interest in this area. We're doing a little bit of research, so great to see other people doing that. I have colleagues who've been started to use some of the AI scribes. However, we got the NHS England letter. We then had a pause, and as data controllers, we've been told we have to do all the regulatory stuff ourselves, and we have unlimited liability. As GPs are independent contractors to the NHS. So everything's gone on hold at the moment, and I'm sure other practices are in the same boat. So I think the technology is advancing so quickly, it's the regulation and the ethical issues which are really putting a bit of a stop block to us. So any thoughts about that, how we might proceed? Because we're not getting any support from ICBs, and at a macro level, ICBs are having a 50% budget cut and NHS England is ceasing to exist. So actually we've got all this kind of technology coming on we'd like to use, but we haven't got any support to use it.
Wow, that's a very topical question, Thomas. And interesting, I was at the Digital Transformation Summit last week in Birmingham, talking to a number of people there. So Modality Partnership use AVTs, have been doing so since I think January, February. They've done their safety checks, clinical safety officers signed it off. So they found a way to do it. And I was talking to a PCN CD next to me, so a clinical director, And I said, where are you at with this? And he said, well, I've just completed my clinical safety officer training. He said, and now I'll be able to sign it off. So what that means is that providers are starting to take on that burden of information governance sign off. But I totally understand it's a massive workload for GPs who already got a massive workload. But that has definitely shifted from ICBs to providers almost ahead of or alongside ICBs having these staff cuts. So it's a very mixed picture across the country. I know ICBs who've looked at ambient voice technology. So, for example, in Kent and Medway, they've looked at it, they've checked it out, and they've said, yes, we believe that it is a good solution for us, and we will do that information governance. Now that's ICB driven, but it's obviously the individual there that's driving, all individuals there that are driving it. And I know other areas have just put it on pause and said, stop using it. We're waiting. I guess the question is, what are you waiting for? Because I can't see, I mean, it's very much a personal view. I can't see who's going to step into that gap at the moment until provider collaboratives or whoever set up that function. And I know provider collaboratives are setting up that function at the moment to step into that gap, but that's very much local solutions.
Thank you.
Thanks very much. Next up, I'll bring in Manzoor Ahmed. That's okay. Hopefully, I've just unmuted you just to speak to the question you put down there.
Hi, yeah. I had actually two questions, and this is really based upon I actually reviewed a paper for the BMJ about ambient scribes, and I think we had a good fun reviewing it. It was from, I think, University of Oxford. And then later, the legislation came to say you can't use it. So anyway, very topical, Jenny, and thanks for the talk. It's very good. So my question really, I'm seeing some, I'm hearing about some consolidation that the EPR companies, they're also creating their own AI scribes. So I'm just worried, what's that going to entail for all these providers that are signing long contracts with these ambient scribe companies, and I'm finding out actually the EPR companies going to also have a solution. So that's one question. And I think the other thing is regarding training. I think we all sometimes use some software we're not really trained at what kind of outputs it produces and how to analyze, what output is, then how to kind of really analyze in depth and see, is there any bias, and then how can we prevent it? Yeah, thank you, Jenny.
Well, firstly, I totally agree on the training. I just hope somebody out there is going to step into that gap and say, this is how we do it. So I don't know the answer to that, but I'm hoping this community and others will be able to find a way. Certainly internally, we talk about it quite a lot in the Innovation Network and how can we help. So we're very happy to talk at webinars and things like that, but that's about raising awareness really rather than education. In terms of the consolidation, you're absolutely right. That is the direction of play in the market. Because actually to create an ambient scribe, as we said, it's relatively easy to do. It's how you then apply it, how you get that template design right to capture the right information in the right format. Because then you get into the coding quality and making sure that that is done correctly too. So that's how things are going. All of the EPRs out there are looking at it. Some are integrating suppliers that already exist. Some are designing their own. Some are in conversations with suppliers that exist about buying them up. So the market is absolutely changing quickly. And you are right to be wary, I would say, if you're going to invest lots of money in one particular supplier, but you've got to find the right one for your use case, and then whatever contract you sign, just need to do it with the view, understanding that the world is changing rapidly, and this time next year will be quite a different picture.
Okay, thank you.
Thanks very much. Next, I'll bring in Samir Ganguly, who has again a kind of question focused on that integration piece you mentioned, and it was interesting to hear what.
Hello there. Thank you. Can you hear me?
Yes, perfectly.
It's lovely to see both of you because we've had email conversations. I know you can't see me. Great lecture, Jenny. Amazing work and great introduction, Jeffrey. Yeah, so in University Hospital Sussex, so I'm the lead for AI, and our team has led some brilliant pilots for AVTs in the outpatient and ED settings. My colleagues might be on the call, I can't tell. And we're now looking at procurement, but we won't have a trust-wide EPR for 2 years. We're currently in looking at procuring that and looking at shortlisting, etc. And prior to that, so we can't fully integrate the ambient voice technology with our existing electronic records because they all vary in different settings. And of course, NHS England have said that for a full deployment, but not a pilot, that ambient voice technology has to be fully integrated with EPR within 2 weeks of deployment. So you can't use copy and paste. And this is understandable from an IG or clinical safety point of view, but currently it's practically not possible. And our clinicians feel that as long as they are safely checking everything, that, as you mentioned, that it's almost better. So what's your advice in this regard? We're kind of in this interim process. Obviously, in 2 years' time, it may be that our EPR, along with what someone else said just earlier, the EPR will provide its own ambient solution. We won't have that for 2 years. There are clear efficiency savings for our ED and outpatients. So what would you advise? There was meant to be an update from NHS England regarding this plea from the healthcare community, but I haven't heard anything myself. I don't know if you have. Thank you.
That is a tricky one, Samir. I've seen some draft, what's the right word, policy on implementation from NHSE. I haven't read it in detail yet. It's sitting there waiting for me to look at and put some views on it. I think my view on this sort of thing is it's one of those things that guidance is often written without fully understanding the impact of the guidance. And therefore, if people like yourself go, look, this is the situation, this is what we're doing, this is how we're ensuring the safety. If it's a way to ensure safety, but it maybe is a slight difference to the guidance, guidance is guidance. And if you take a different view because of local factors, I think that is worth exploring further. I'm trying not to say anything that gets me into trouble, but that's how I would approach it. And I've certainly done those sort of things in the past in terms of exploring guidance further, looking at the local application, saying, can we make a case to do this for this amount of time with this mitigation for this reason? And if you want to pick up separately, I'm more than happy to do that.
That's really helpful advice. Thank you so much. Thank you, Jenny.
Thanks both. That's great. Next, I'd like to bring in a colleague from a social care background, Caroline Webb. Hopefully, Caroline, you can speak.
I can speak. Thank you, Jeff. Can you hear me?
Yep, loud and clear.
Great. Thank you. Thank you, Jenny. That was really interesting. So as Jeff said, my background is in children and family social work, and I think we're just really starting to see AVTs take off, as you've said, particularly Magic Notes, which is a leader. I was interested in the evaluation that you were referring to in Medway. It seemed to have some very, very positive outcomes there. And I wasn't sure whether or not that was against adult social care or children's social care. So I was actually talking with a local authority earlier today who's just finished a 6-week evaluation of Magic Notes in children's social care across 2 different teams. And they didn't necessarily see such an obvious impact, although practitioners were very positive about it. Trying to translate that into actual sort of outcomes for children and families was much more complicated, and they are pausing before commissioning it. So I just wanted to unpick that a little bit more, because the two for me were sort of opposing evaluations.
That's really interesting to hear, and I'm again happy to pick up with you afterwards and look at it in more detail. But this one was in adult social care. It was occupational therapy and care needs assessment.
Okay. So
my understanding of those assessments, you'll know far better than me, they take, one of them takes up to 2 hours to do and up to 6 hours to write up. So the other place that we've seen those assessments, sorry, slightly different use case, but in mental health for the ADHD and autism assessments, I think that use case, I'll need to double check because it's been done in London. It's not our patch, but that's looking at both adult and children, I think. But this was only adults, and it was, I could say, across 29 staff members. I mean, I think we were all surprised how significant it was. I don't know what that says about how. I mean, for some people, they may be working more efficiently or have other tools. It also depends what you measure. So I think, therefore, with evaluations, it's a case of having to compare what was being measured and why. But yeah, this one was particularly good. But we have seen similar.
It's strikingly good. Yeah. So, okay, thank you, Jenny. It may be interesting to pick up with you separately.
Please do. Yeah.
Thanks very much. Next, we've got a question from Kevin. Kevin Varghese Philip. Hopefully you can speak. Do you mind giving it a go?
Yeah, can you hear me?
Yep. Brilliant. Over to you.
Yeah, hi Jenny. First of all, wonderful presentation. So my question is from a software developer or a founder perspective. It's regarding if someone developed a software and it can positively influence patient pathways or treatments, how fast the NHS trust can implement it, or what are the procedures they have to follow? Oh, it's completely from a founder perspective, and how can a trust actually, in a pilot basis, implement it and eventually give it a green flag?
The very short answer to that, Kevin, is a very long time. Just to manage your expectations. Getting any new product into the NHS to procurement stage takes years. Now, this world isn't a world that's measured in years in terms of the world of AI, but it is hard. So the people that tend to do best are those that work with clinicians. So they've already got a way into a test bed and somewhere to try things out safely. Doing it outside the NHS and then trying to sell into the NHS without any sort of co-design work is extremely difficult. And the Health Innovation Network, we exist to try and help bridge that gap between innovators and health and social care settings. But we see a number of technical innovations coming across our desks regularly. And if they haven't got any sort of clinical foundation or understanding, it is something that would be very hard to move forward, because there'll be so many barriers to entry. I think the other thing just to make you aware of is that we also get an awful lot of innovation that comes to us from the States, from all over really, but quite a lot also from Scandinavia and other parts of Europe. So there's a lot of choice out there, and the NHS is rightly very wary of new tech if it hasn't got kind of clinical input to it.
Got it. Thank you.
Okay.
Thanks very much. So just as we're probably moving towards the last few questions, so if you do have anything you want to add, please do to the audience, add it to the Q&A. Just pulling together some of the sort of anonymous type questions I'm seeing. In these evaluations, what was the approach to transparency with patients? How were they made aware of the products being used in the care they were delivered? And what was the approach with consent around that as well?
So all the areas did some kind of patient engagement beforehand through their trust, might be in a patient group or something similar. So some settings had sort of more patient involvement than others, but all asked for consent at the time. So if it was in a patient setting, a healthcare setting, at the time of use, it was, we are trialing this. Are you happy for us to record the conversation? Generally, it would be added with something like, it helps us. We're trying to see if it helps us be more efficient or capture more data or something of that sort. So the words would have been agreed with that particular group for that particular setting. And in the the social care setting, they did, again, they asked the people on the sort of receiving the care and support if they would consent to the conversations, assessments being recorded. So it was asked for in each particular conversation, each particular consultation.
Right, thanks. And thinking as well from your experience of seeing the performance in different settings, and also perhaps the experience your colleagues have from what sounds like quite a sprawling array of pilots now, what do you think moving forward the need will be for evidence generation at a site-by-site level? Do you anticipate that any adopter, good practice for any adopter would be to do a local evaluation of some form before committing to it? Or will there be a point where enough of these evaluations have accrued that we can be happy that it generalizes to this setting and that setting? And same again for monitoring. I know you kind of touched on it, but any thoughts you had around that? Not expecting, I think the answer around this will probably take a long time to drop out, but it'd be great to hear what your musings are on it.
So I think taking the evaluation point, I would hope that we could stop evaluating fairly soon, in terms of we should build up a bank of, here's the evaluations that have happened. So we had an example from Caroline of, an example in social care in children's services versus adult services. So obviously different sites and different types of user will have different experiences. but once we've got a few of those for each setting, that's enough. The NHS does suffer from pilotitis. People are always wanting to do a pilot because you don't know how different it is in Kent versus Sussex versus Surrey versus Hampshire versus London, and generally speaking, these they're fairly similar. There is local need, absolutely, but that's more about sharing best practice, I think, and understanding implementation. I think absolutely we should be sharing implementation learnings more, and why it is that some places are better at adopting new technology than others. But you do need a central place to capture all of this information. And actually, I was talking to one of my colleagues yesterday about within our health innovation network, we could probably do that a bit better, so each of us can know what's going on rather than me messaging all my colleagues going, where have you got to with that evaluation, where have you got to with that one. And then, of course, the monitoring side. I mean, the answer to that normally is the clinical safety officer for that setting would set up the appropriate way for that particular setting. So it may be auditing the notes, I don't know, every few weeks to check, do they comply? Has the note been checked? So where people are copying and pasting, or where they're pressing a button, you can look and say, did they press the button within 5 seconds of the end of the consultation or 5 minutes of the end of the consultation? Because that gives you an idea how they're doing that. But there's the accuracy check as well, or do you get a second person in to sign it off? I mean, there will be much cleverer ways than that. So I guess the short answer is I don't know.
But those are really helpful insights and heartening when you say thinking of the burden on local adopters of having to do all these evaluations, that there may be a point where monitoring or lighter touch can be taken. Just riffing off that as a kind of last question before we close, were there sort of settings or subgroups for which you think that the technology might not be there yet, or it might be wise to avoid its use in those particular?
I think the most difficult use case that we came across was one where you are assessing children who maybe have some sort of whatever their health issue is, which means that they act out as well as speak. So a lot of non-verbal cues are given. So what you capture verbally is clearly not the whole consultation by any means. And therefore, if you're not careful, you only get half of a consultation recorded rather than the full one. So that setting, I think, is tricky and probably not necessarily an appropriate use case, unless it is sort of adapted very, very cleverly and carefully.
Yeah, that makes a lot of sense. I can see that. Well, thanks again. I mean, I think it's pretty obvious from the degree of engagement and questions that it's a really valuable talk, and I really appreciate you making time to join us, Jenny. Thanks so much.
My pleasure.
And just as we close out, just to let the community know that our next meeting for a webinar is on Wednesday, the 22nd of October. And we'll be joined by Dr. Rydian Bramley, who's a consultant radiologist and clinical AI lead at the Greater Manchester Cancer Alliance, who'll be talking to the title of Making the Case for Chest X-ray AI and the Role of Automation. So we hope to see you then too. Thanks once again, Jenny, for joining us, and look forward to seeing you all next time. Enjoy your evening.